Good evening, everyone. A very warm welcome for today's webinar on critical review of ASCO 2025. I am Dr. Khushi Singh, and it is truly a pleasure and privilege to host this important academic session. ASCO remains a landmark conference that showcases the latest advancement in cancer care. And through today's discussion, we hope to reflect on key updates that meaningfully impact on our clinical practice. It is indeed a great honor for me to hand over the session to Dr. Anbrashan Shekhar. He is an assistant professor, ACTRC, Mumbai. And now Dr. Advita Gore is an associate director, Department of Medical Oncology and Precision Medicine at Nanavati Beck Super Specialty Hospital, Mumbai. And next, Dr. Ravi Jaiswal is a consultant medical oncologist, hemato-oncologist at Rama Krishna Care Hospital, Raipur. Dr. Rushabh Kothari is a consultant medical oncologist and cancer care Narayana Multi-Speciality Hospital, Ahmedabad. Dr. Shamir is a consultant medical oncologist, National Cancer Institute in Nagpur Care Hospital, Nagpur. Dr. Pinaki is a consultant medical and pediatric oncologist at the SCG Cancer Center, Baroda. Dr. Tejender is a senior medical oncologist at Apollo Hospital, Navi Mumbai. Now I would like to hand over the sessions to Dr. Anbrashan Shekhar. Sir, over to you.
Hello. Good evening, everyone. I would like to thank organizers and Advani sir for giving me this opportunity. Today, we are going to quickly discuss about Serena 6 trial, which is nothing but about camizestrant in combination with CDK4/6 inhibitor with the emergence of ESR1 mutation during first-line endocrine therapy-based therapy and ahead of disease progression in hormone-positive, HER2-negative advanced breast cancer. Next slide. So what are the three key takeaways with this study? Because one important key takeaway is we can monitor for arrival of ESR1 mutation in the blood, and based on which we can act upon it. By acting upon this ESR1 mutation, we can have a PFS advantage from the utilization of camizestrant in this part. Next slide. The background behind the study is we know that ESR1 mutation is very common in the upfront setting, but after usage of CDK4/6 inhibitor along with hormone therapy, the percentage is almost 40%. Next slide. And utilization of camizestrant comes in the picture that utilization of camizestrant come with the picture that it acts both in the mutant as well as normal ESR1, so it benefits better. And we all know that by tracing ESR1 and changing the line of therapy in PADA1, it has shown a significant difference, and Serena 2 has shown beneficial effect with usage of camizestrant. So idea with Serena 6 is why can't we use camizestrant instead of fulvestrant in the study scenario? Next slide. This is a very interesting study. It has its own set of challenges because we need to screen a lot of patient for ASR1 mutation over a period of 2 months or 3 months duration, and then it should be followed up for a long period of time. So almost 3,300 patient has been screened into the study design, which 548 patient on whom ASR1 has been detected, and among the 548, only 315 has been randomized into the 2-arm. It is a 1:1 ratio. Next slide. Coming to the study design, all the advanced HER2 positive, hormone positive, HER2 negative patient taken into the study design who have received AA along with CDK4/6 inhibitor into the study design, and they have been monitored for the arrival of ASR1 mutation. Once ASR1 mutation is detected without any frank disease progression, they have been randomized into camizestrant compared to AA with continuation of the previous line of therapy. And the key stratification factors are visible versus non-visible disease, arrival of ASR1 mutation, whether at the first test or subsequent test, and the timing of initiation of AA with CDK4/6, whether it is less than 18 months or more than 18 months, and the type of CDK4/6 inhibitor has been used into the study design. The primary endpoint is progression-free survival. Secondary endpoints include progression-free survival 2, overall survival, safety, and patient-related outcome. Next slide. So this is with respect to the enrollment and the statistical design, how the primary endpoint has been defined. And the secondary endpoint is the time from the onset of for the second line of therapy till the time of progression for the second line of therapy. And data for this study is still yet to mature in this scenario. Next slide. So this is with respect to the baseline characteristic feature. The arm has been bilaterally randomized in a good fashion. One thing I would like to highlight over is almost 76% of patients received palbociclib as the preferred CDK4/6 inhibitor, and more than 62% of patients had AI plus CDK4/6 inhibitor more than 18 months. So that is also key features which influence the importance of drug in this study. Next slide. And this is with respect to the primary endpoint. There is a PFS advantage is there, which is the primary endpoint. Almost doubling of PFS is seen. In the control arm, it is 9.2 months, whereas with the experimental arm, it is 16 months. And the PFS advantage started early, unlike other hormone-positive breast cancer setting, where the curve tends to hug each other in the initial setting. Later on, only we see the advantage. Here, we are able to see the advantage as early as possible. And this advantage is maintaining over a period of time also. Next slide. And this is with respect to the subgroup analysis. As I mentioned earlier, we have stratification factors for mainly 4 different things. One is with respect to the type of CDK4/6 inhibitor. When the patient has been abemaciclib as the preferred CDK4/6 inhibitor, the response is not that great. And irrespective of presence of visceral or non-visceral metastasis, it seems to be much better option. And the drug works better when the patient had response more than 18 months with the previous AI along with CDK4/6 inhibitor. In those subsets, it seems to be work in a better fashion. Also, it has shown much good response in the presence of ESR1 mutation treated in the first time of testing. During the subsequent time of testing, it is not showing touching the line of median. Next slide. And this is with respect to the key secondary endpoint include time to duration in health quality of life. Why it is important? Because we are adding newer therapy, and whether it is affecting the quality of life is there or not, it is not affecting the quality of life. The median time to deterioration in the arm is 23 months. In the comparator arm, it is 6 months. So the quality of life is not affected by the addition of newer therapy, and it is statistically significant also. Next slide. And this is another important secondary endpoint, that is progression-free survival 2. Here also the progression-free survival advantage, PFS2 advantage is also there with an adjusted hazard ratio of 0.52. But little small caveat over here, because the preferred second line of option in those patients with camizestrant is preferably chemotherapy, whereas in those patients who are endocrine therapy, the percentage of chemotherapy utilization in camizestrant arm is almost 10% higher compared to the control arm. So that is also one kind of deviation factor for this higher PFS2 advantage in this scenario. So we need to wait for the OS data to see the actual result. Next slide. And coming to the safety profile, when we look at the initial heading, almost 90% of patients having side effect and 60% of exhibiting grade 3 side effect. But when we look a little bit further, the serious adverse event percentage is only 10%, and the drug discontinuation rate is less than around 1% only. This again shows that the drug is quite safer, and the relative dose intensity also maintained close to 99% of patients. This shows the drug is safer. Next slide. Coming to the various side effects, the predominant side effect is hematological. Main reason is should be combined with CDK4/6 inhibitor. That's why the incidence of neutropenia, anemia, and leukopenia are slightly higher. And other side effects like key side effect which we need to note down is photopsia. It is one of the things which is seen over here. And rest all related to the AI as well as anti-hormonal therapy side effects is seen. And those side effects are comparatively lesser compared to the hematological toxicity. Next slide. Coming to the conclusion of the study, switching to AI to camizestrant in patients who are detectable ESR1 mutation definitely have a PFS advantage, and this benefit is seen across all the CDK4 subgroup and clinical relevant subgroup like presence of visceral metastasis is there or not. In all those subgroup, it is showing the beneficial effect. And Serena 6 is the first global registrational phase 3 trial to demonstrate clinical utility of ctDNA monitoring to detect and treat emerging resistance in breast cancer. With this, I would like to thank the organizer for giving me this opportunity. Thank you.
Thank you so much, sir, for the educational talk. So now I would like to invite Dr. Advita Gore, sir. Sir, the stage is yours.
Yeah. Hi, good evening. Good evening, everyone. So today I will be discussing about the uh, INAVO 120. This was a phase 3 trial which was presented at ASCO this year and then also coming out as a New England Journal of Medicine publication. When we are looking at INAVO 120, this has been a journey from the phase 1 study, which was reported about in San Antonio 2021. And then subsequently, we've seen the PFS data being published at SABCS last year. And this is the overall survival analysis. What this is looking at PIK3 kinase mutations, which are seen in about 40% of patients with hormone receptor positive, HER2 negative advanced breast cancers, mainly carry a poor prognosis, and they respond to a PIK3 kinase inhibitor. In these cancers, combining the blockage of hormone pathway, CDK4/6, and the PIK3, which are key drivers of cancer cell survival, whether it adds benefit. Now, inavolisib is an oral potent. This is a very selective PIK3 isoform A inhibitor or isoform alpha. We know that PIK3 kinases has 4 isoforms, beta, delta, and gamma are the other 3. We have already alpelisib, which is not a very selective inhibitor, and it's a very difficult drug to actually manage the toxicity in patients. And this study looked at combining Inavo plus Palbo and fulvestrant at a single dose as treatment. All these patients had a poor risk criteria, meaning they had all progressed during or within 12 months of adjuvant endocrine therapy completion, which indicates that these are possibly primary resistant or they may have harboring ESR1 mutation, as we know that patients pre-treated with AIs do get ESR1 mutation due to selection pressures. All of these patients were tested for a PIK3 kinase mutation. This was either with a tissue or with a liquid biopsy with a ctDNA. The companion diagnostics which have been approved with the use of this drug is the foundation medicine, but the ctDNA was done with the Guardant 360 platform. There was no prior therapy for advanced breast cancer, which was allowed. And because hyperglycemia is the most common side effect of these drugs, patients were eligible if their fasting glucose was less than 126 or their HbA1c was less than 6. 1:1 randomization of 325 patients to Inavo plus Palbo and fulvestrant versus palbociclib and fulvestrant. And they were also stratified based on whether they had visceral disease, whether they were endocrine resistant, primary or secondary. And the primary endpoint was the PFS, secondary endpoint was overall survival, investigator assessed overall response rate, clinical benefit rate, duration of response, and patient reported outcomes. Now, this is the primary result analysis, and primary result analysis showed that there was a statistically significant and clinically meaningful benefit in terms of favoring the combination of the PIK3 kinase CD46 as well as fulvestrant. PFS adult ratio is 0.43, median PFS of 15 months versus 7.3 months. You see almost doubling, and in certain time points, we are even looking at tripling of the PFS. Overall response rate 25% and 58%. Data cutoff was in November 2024. This is the Inavo update, where the main reason for treatment discontinuation in patients was progressive disease. This was the updated PFS, again at the data cutoff at November 2024, where median PFS is 17.2 months versus 7.3 months. Really good hazard ratio of 0.42. This is the key secondary endpoint of overall survival, 34 months of median overall survival versus 27 months, favoring the triplet combination. And this did cross the pre-specified boundary for the statistical significance, and the median delta is about 7 months. In terms of subgroups, irrespective of the age, whether PS0 or 1, pre or postmenopausal, the patients had visceral disease or not, the benefit with the triplet was generally consistent. In terms of site of metastasis being 1, 2, or more than 3, whether the patient had PR negative or PR positive status, whether previous endocrine therapy was an AI, tamoxifen, sequential, or only AI, or only tamoxifen. Again, we see that this was generally better across all subgroups. Now, what happened to patients who progressed? The INAVO 120 post-progression therapies, we see that almost 55% patients who received INAVO went on to receive second-line chemotherapy, and third-line was received by almost 85% of patients. Antibody drug conjugates were received in third-line predominantly in about 20% patients, and any other PIK3 inhibitor was seen only in 6%. When we look at other key secondary endpoints of overall response rate, 62% versus 28%, the duration of response 19 months versus 11 months, and the time to subsequent chemotherapy was about 3 years in patients who received the triplet combination as opposed to only 12 months where patients were subjected to only CDK4/6 and fulvestrant. So in terms of adverse events, we've all have burnt our fingers using alpelisib many a times. And this is a drug which seems to be better than alpelisib because it has a selective inhibition of only the alpha isoform. Only 7% patients discontinued therapy while on the drug. And in terms of toxicities, we do see that stomatitis is a common toxicity, and but grade 3, grade 4 is only in about 5%. So dexamethasone gargles, as we prescribe to all our patients on everolimus, is a must when this drug is prescribed. Hyperglycemia, grade 1, grade 2 is common in more than 60% of patients. However, grade 3, grade 4 hyperglycemia is in single digits. Rash is something which is grade 1, grade 2 in about 1 in 4 patients. Alpelisib does have a lot of issues with the rash, but here we do see that grade 3, grade 4 rash are very, very minimal. The limitations of this study were that when the study was designed, palbociclib was the only drug which was available with a data of PFS benefit. That's the reason why Pibo plus fulvestrant was the study arm. Now we have Ribo and Abima, and these combinations are being currently assessed in the Morpheus pan breast cancer study. There have been few patients who have received previous adjuvant CDK4/6 inhibitors, but they formed only about 1.2% of the population. Another study which was also looking at whether alpelisib in second line or in second line with fulvestrant is a better option. So there is a INAVO 121 study which is ongoing. And the subgroup analysis of a secondary endpoints do have a criticism that they were relatively small patient numbers in those groups. The key takeaways are the triplet combination compared with CDK4/6 and fulvestrant in a PIK3 kinase mutated hormone receptor positive, HER2 negative endocrine resistance advanced breast cancer. This is the first time that the overall survival has been significantly improved by a PIK3 pathway targeting drug. The previous reported improvement in PFS was maintained during longer follow-up, and median time to subsequent chemo was delayed approximately by 2 years. Hyperglycemia, stomatitis, mucositis, dry eye, bloody vision are reported at a higher frequency with the PIK3 kinase. However, there was a very low discontinuation rate due to adverse events. This is a snapshot of the publication which came in, and I thank the organizers for having us here, and we look forward to the discussion. Thank you.
Thank you so much, sir, for the insightful talk. So now it's my pleasure to invite Dr. Ravi Jaiswal, sir. Sir, over to you.
Ravi, you're on mute. Ravi, you're on mute.
Good evening, everyone. Thank you, Advaita sir, for informing me that I'm on mute. Is my screen visible?
Yeah, yes, sir, it's visible.
I can't see your slides. Yeah, now yes.
Yeah. Are my slides visible?
Not as of now.
Not as of now. Now are they visible?
Yes.
Yes. So I am going to talk about vepdegestrant, a PROTAC ER degrader versus fulvestrant in ER positive, HER2 negative advanced breast cancer. Results of the global randomized phase 3 VERITAC-2 study. So mind you that VERITAC was a global a study and India was part of it. So whatever results we have, so there are Indian patients in the study. So that reflects on us. So vepdegestrant is a new drug that we have, and PROTAC is a new concept that we are talking about. So what is PROTAC first of all? PROTAC is a proteolysis targeting chimera. So this is the first time that a drug of this class is evaluated in a phase 3 study. Oral vepdegestrant was well tolerated and demonstrated statistically significant and meaningful improvement in PFS versus fulvestrant in patients with ESR1 mutant. Results of the phase 3 VERITAC study support vepdegestrant as a potential treatment option for previously treated ESR1 mutant, ER positive, HER2 negative advanced breast cancer. So, uh, uh, there's no established consensus for treatment of ER positive patients after they progress on first line ET. So the standard of care that we all follow is CDK4 plus ET in our practice. And after that, there's hardly options that are sequentially lined up for us. Fulvestrant is one drug that we use, which is a SERD that is administered intramuscularly due to poor solubility, but it has a limited PFS benefit. Now, vepdegestrant is competing against this place. This is a selective and it is a oral PROTAC ER degrader that targets the wild type as well as the mutant estrogen receptor. So in the first in human phase 1/2 study, vepdegestrant was well tolerated, and this demonstrated a clinical activity in uh, heavily pre-treated patients. So the now we have evidence that this drug works in heavily pre-treated population. So the eligibility criteria for this study was age more than 18-year-old patients who are ER positive, who have received first-line CDK4 with endocrine therapy. Less than one additional ET was approved. That means that only one line of therapy was allowed for this patient, and the most recent therapy was more than 6 months. The patient should not have received prior SERD. No prior chemotherapy for advanced disease was allowed, and radiological progression during or after the last line of therapy. And they were randomized 1:1. Vepdegestrant is a 200 milligram oral drug. So it is given 28-day treatment cycle versus fulvestrant. So we know fulvestrant 500 mg day 1, day 15 first cycle, and then monthly once. The stratification factor was ESR1 mutant, whether it was present and absent, and visceral disease, yes versus no. The primary endpoint was PFS, which was by blinded central review. First, they were supposed to test this in ESR1, and if it is positive, then for all patients, the secondary endpoint, overall survival, and clinical benefit rate. So this was the statistical hypothesis. So first, the hypothesis was tested PFS in ESR1 mutant population with a predefined hazard of 0.60. And if this was positive, it was for intention to treat population where the hazard was 0.67. And if this is positive, the hypothesis pre, that is OS for ESR1 and OS for intention to treat. So a well-planned study design, I would say. In the patients who were randomized, 300 patients in each arm, so quite a big number of patients. Out of that, ESR1 mutant in each group is around 136, so that means around 35-40% of patients. And out of these patients, uh, who went on to receive this drug, the baseline characteristics of the patients were almost comparable. So I cannot see anything outlier that we can discuss here. PFS by which was the primary endpoint by blinded central review. So this is the data, and if we see in the fulvestrant group, it is median PFS is 2.1 months versus the vepdegestrant group where it is 5 months. So 2.1 versus 5 with a hazard of 0.57. So that meets the endpoint where it was set up at 0.60. So this is significant at a median follow-up of 7 months. If we look at for all the, that was for ESR1, if we look for all the patients, it is 3.6 months versus 3.7. So now here this doesn't fit into the predefined hypothesis. That means we are getting PFS in ESR1 mutant population. So the investigator assessed PFS again in the median, we see it is 2.8 in the fulvestrant group on the left side versus 5.4 months. For all patients, it is 3.6 versus 3.9 months. If you look at subgroup analysis as to where the PFS is actually benefiting and not benefiting, I think only one thing here is that ESR1 population, everyone is benefiting. And within ESR, if we are trying to look at whether it's a visceral disease, liver disease, I think there's no outlier where it doesn't work. But earlier the better, because if it is more than two lines of therapy there where you have 18 or 19 patients, there the hazard ratio is 0.86. When we talk about overall survival, we don't have overall survival as of now. The data is immature. So deaths occurred in 43 patients in the ESR1 mutant group and 80 patients overall. The secondary endpoints, which is the CBR and ORR. So the clinical benefit rate is better than the fulvestrant, 20 versus 42 in patients who have ESR1 mutant. For all patients also, it is slightly better, 28 versus 34.3. If you look at the safety and tolerability of this drug, the grade 3 toxicities are almost similar to the fulvestrant group. So we are not encountering any serious adverse events with this new drug. The common toxicities seen in these studies are fatigue, which is seen in 27. That is 27 out of your 312 patients getting any grade. So I think that's not very significant. Apart from that, there's ALT and AST increase, nausea, anemia. So the drug is safe, no new safety signals. To conclude the trial, vepdegestrant is the first PROTAC to be evaluated in a phase 3 study. Oral vepdegestrant demonstrated statistically significant and clinically meaningful improvement in PFS by blinded review versus fulvestrant in patients with ESR1 mutant ER-positive advanced breast cancer. OS analysis is immature, and vepdegestrant demonstrated a favorable safety profile as evidenced by fewer adverse events leading to dose reduction or discontinuation. So these results support vepdegestrant as a potential treatment option for previously treated ESR1 mutant ER-positive advanced breast cancer. So this is the acknowledgement slide where we can see that this study was conducted in 213 sites across 25 countries, and India was part of this. Thank you so much for your attention.
Thank you very much, sir, for the educational conversations. So now I would like to invite Dr. Rushabh, sir. Sir, over to you.
Sure, I'll just share my screen.
Sir, no worry, we will share from our end if you are okay.
Yeah, that would be fine if even if you are sharing.
Okay, thank you.
Okay, so I will be discussing Ember 3 trial. So the data for efficacy was already out prior. Here, patient-reported outcomes were reported in this ASCO 2025. So a brief on what was there in efficacy and what was the trial design. So ER-positive, HER2 negative advanced breast cancer, pre and post-menopausal women and men, both everyone were allowed. Prior therapy, if it was adjuvant, it has to be recurrence on or within 12 months of completion of AI plus CDK4/6 inhibitor. And if it was after, in advanced cases, it has to be progressed on first line AI plus CDK4/6 inhibitor. No other therapy for advanced breast cancer was allowed. Stratification factors were prior CDK4/6 inhibitor, visceral mets, and region. There were three arms. First was oral SERD, imlunestrant alone. Second is physician's choice of treatment. It was fulvestrant or exemestane. Third was imlunestrant plus abemaciclib. So patient-related outcomes was an exploratory analysis which we would discuss in detail. Next slide, please. We will take a look at couple of efficacy slides. In patients with ESR1 mutation, oral SERD was doing better than standard of care endocrine therapy. Median PFS was 5.5 versus 3.8 months with hazard ratio of 0.62, not crossing unity. And if you take all patients and we take arm C, which is oral SERD plus abemaciclib versus oral SERD alone, it was 9.4 versus 5.5 months with hazard ratio of 0.57, not crossing unity and a significant p value. Next slide, please. So toxicity wise, oral SERD alone was safe when compared with standard of care endocrine therapy, and there were no specific ocular or cardiac toxicity which we see with some of the oral SERD. If we take combination of imlunestrant with abemaciclib, uh, it was typical. The toxicity profile was matching with what we see with abemaciclib. Uh, Diarrhea, neutropenia, and other cytopenias were the major concerns. Next slide, please. So in this presentation, they reported patient-reported outcomes, which were based on EOTC QLQ C30 scores, uh, which had global health status and quality of life, both functional and symptoms. They had a specific PRO for CTCA diarrhea, for injection site reactions, and EORTC IL-19 for physical functioning. So these were the things which were measured during the course of treatment. Next slide, please. So this is comparison between oral SERD versus standard of care endocrine therapy in ESR1 mutated patients alone. So it is global health status. Here we can see that uh, there was a delta of 9.9 points between imlunestrant and standard of care endocrine therapy. So if it is less than 10, then both are considered equivalent. If it is beyond 10, then it is considered meaningful. So here it was 9.9. Next slide, please. Time to deterioration, again, it was 5.6 months versus 3.8 months. Again, this is for ESR1 mutated patients alone. So this was the quality of life and global health score was equivalent, though numerically favorable in imlunestrant arm, but it was statistically significant. Hazard ratio is not significant because hazard ratio was crossing unity. Next slide, please. So now this is overall global health score with quality of life and functional domain on treatment. Again, it is for oral SERD versus standard of care endocrine therapy in ESR1 mutated patients. So the scores which we see plus scores are for oral SERDs, the green one, and the orange one are for standard of care endocrine therapy. Again, in most of the domains, oral SERD is doing better, but a 10-point difference is needed for it to be called significant. It was not there, so it would be told that both of them were similar. So general quality of life and functional domains both were generally maintained across both the treatment arms. Next slide, please. Again, in symptom domains, because there is no 10-point difference in any of the symptoms, it was broadly similar across both the arms. Next slide, please.
Yeah.
So this is QLQ C30 scores. If we see, most of them are favoring oral SERDs. So treatment difference generally favored oral SERD compared to standard of care endocrine therapy, whether it was functional or symptomatic domain, but many of them are crossing unity. So probably when we compare both the arms, quality, the QLQ C30 score is similar in both the arms. Next slide, please. Yeah. So If we take injection site reaction, around 72% patients on standard of care therapy had complaints of injection site reaction. For especially, we know that pain, swelling, and redness is common with fulvestrant, especially if it is taken for prolonged period of time. So most patient experienced injection site reaction with fulvestrant. Next slide, please. So now this is overall global health score and quality of life in functional domain when oral SERD plus abemaciclib versus oral SERDs versus standard of care. All three are compared. Again, there is no 10-point difference uh, between any of the arms. So it would be called that generally it is maintained well across all the three treatment arms. But if we see again, when there is combination of oral SERD plus abemaciclib, the quality of life difference is reaching very close to 10. Next slide, please. And symptom domains, if we see diarrhea, nausea, vomiting, there is 10-point difference when oral SERD plus abemaciclib is used compared with oral SERD alone or standard of care endocrine therapy. So in some symptoms, there is a difference which is significant. Otherwise, other symptom domains were more or less similar in all the three arms. Next slide, please. So, overall conclusion, global health status, quality of life, and functional domains were maintained across uh, both the arms, oral SERDs versus standard of care arms. And when we take combination of oral SERD plus abemaciclib, there were some differences, especially in GI related toxicities, nausea, vomiting, and diarrhea, where the oral SERD plus abemaciclib arm did worse compared to the other two arms. When we see standard of care versus oral SERD arms, especially in ESR1 mutated patients, longitudinal and time to deterioration both were more or less similar. There was trend towards improvement in oral SERD alone arm, but statistically it was not significant because 10 points were not crossed. And a lot of patients, around three-fourths of the patient had complaint of injection site reaction with fulvestrant, which was standard of care endocrine therapy. So when we know that there is efficacy and toxicity profile is favorable, patient reported outcomes are important, and these patient related outcomes reinforce the benefit of oral SERD as monotherapy compared to standard of care endocrine therapy in ER positive, HER2 negative advanced breast cancer. Thank you.
Thank you very much, sir, for the knowledge-rich talk. So now I would like to invite Dr. Sameer, sir. Sir, over to you.
Yeah, I'm audible.
Yes, sir, you are audible.
Yeah, thank you. So good evening, all of you. So I think I will share my slides. Is that okay?
Yes, sir, it's okay. But if you want, we can share from our end as well.
Okay, you can share them.
Okay.
So today I'll be discussing the final study, which is also called as MA40 study, which is basically a randomized phase 3 trial of combination of fulvestrant plus ipatasertib as a treatment for advanced HER2 negative ER positive breast cancer following progression on first line CDK4/6 inhibitor and aromatase inhibitor combination. Next slide. This will take we'll discuss at the end of the presentation. You can go to the next slide. So now coming to the background of this study. So we all aware the standard of care for the management of ER positive, HER2 negative MBC patient has been combination of CDK4/6 and endocrine therapy since last 10-12 years, and we have been using it routinely in all our patients. But we have seen most of these patients progressed over a period of time, generally after a period of 2-3 years, and always there is a need for next line therapy. We have already seen 2 abstracts today in this group of patients. So this will be a third targeting this population. So we know there are common resistant mutation which can be encountered in this group of patients. So PIK3C is one of the common mutation seen in this group of patients when there is a progression on the CDK4/6 plus endocrine therapy combination. In addition to PIK3CA mutation, loss of functioning PTEN protein is also there, which is a tumor suppressor protein, which is also involved in the PIK3CA AKT pathway. So that is also one of the resistant mutation which can be seen in this group of patients. So that's why there is a need for developing a targeted therapy which can over counter this resistant mutation so that we can have new options available. So iptasertib is one of that drug which is a potent and selective inhibitor of AKT, which is one of the protein involved in the PI3K AKT pathway, and it is the pan AKT inhibitor which inhibits all the 3 isoforms, that is AKT 1, 2, and the 3. Similar to the iptasertib, there is one more drug that is capivasertib, and there is already a published trial combination, that is Capitilo 291, and it has shown that capivasertib and fulvestrant has shown a PFS benefit in the AKT altered cohort, and it has led to the regulatory approval in the countries like Canada, Europe, and US. So there is already a drug which has shown the efficacy in this setting. Will be now discussing a similar drug, that is iptasertib, in this group of patients. Next slide. So this is a slide showing the trial design. So this study has included stage 4, that is upfront stage 4 ER positive HER2 negative breast cancer patient previously treated in the first line setting with CDK4/6 and AI. So this is a second line study post progression of CDK4/6 and AI with the ECOG PS 0 to 1 with a measurable disease. So the patients were randomized after progression to either iptasertib plus fulvestrant, which is the experimental arm, to the control arm, that is placebo plus fulvestrant, and patients were stratified using cell-free DNA certification, that is PIK3CA AKT PTEN AKT altered patient versus wild type. So patients were certified using this cell-free DNA testing using Foundation 1 as a companion diagnostic test, and patients were stratified to see whether the pathway is altered or not, and also one of the stratification was primary versus secondary endocrine resistance. And the primary endpoint in this study was PFS in the intention to treat population, and the secondary endpoint were PFS in BICR by BICR in intention to treat population, that is blinded independent committee review, and also in the AKT altered cohort. Other secondary endpoint was OS, adverse events, and quality of life. Next slide. Now coming to the statistical design, I'm not going in details of this statistical design, but we have to understand they have used hierarchical testing procedure. So basically they have tested first the PFS in intention to treat population, and the next PFS assessment, that is PFS in the AKT altered pathway, was done only if there is a benefit of PFS in the intention to treat population. So that's why they have used the hierarchical statistical testing procedure. This study was conducted between January 21 to 24 across different sites in Canada, Australia, and New Zealand. So it was a multi-center study. Next slide. You have to note that the Indian patients were not included in this trial. So now coming to the baseline characteristics, you can see here the baseline characteristics were fairly balanced in the both arm with a median age of 60 years. Few points which can be highlighted here is that patients with less than 6 months of prior CDK4/6 inhibitor therapy was only 8% and 4%. So less than 10% of the patients were received therapy with CDK4/6 inhibitor in first line for less than 6 months. So that means primary endocrine resistance patients were very few, and majority of the patients were secondary endocrine resistant patient, that is they received CDK4/6 inhibitor for more than 6 months of duration. One more point which can be highlighted here is that almost 45% of the patients were PI3K, PTEN, AKT altered pathway, and 55% were wild type or unknown. So almost equal number of the patients were wild type and altered patients. Next slide. Now coming to the results, which was the PFS in intention to treat population. So there was clear-cut PFS benefit with ipadasertib arm as compared to the placebo arm, that is 5.3 month versus 1.94 month, with a hazard ratio of 0.61, with a significant p-value of 0.0007. And here we can see the curves are clearly separated from each other, with a clear benefit of ipadasertib as compared to the placebo in this trial. So that's why this was clearly a positive study. Next slide. Now, if you see the PFS subgroup analysis as per this forest plot, most of the patients benefited with the addition of ipadasertib to fulvestrant, irrespective of the age, ECOG status, and the sites of met, that is liver or lung. But notably, in the patient with CDK4/6 duration less than 6 months, the benefit was not there. And the reason behind this may be very few patients were with CDK4/6 inhibitor less than 6 month duration, only 15 patients. So that might be the reason. That's why any conclusion cannot be drawn from this subgroup analysis. But if you see, the rest of the patients benefited by the addition of ipadasertib. If you see the patient with AKT pathway altered versus wild type, the benefit was more in altered population as compared to the wild type population. So that one point which can be highlighted here. Next slide. Now coming to the secondary endpoint, that is PFS in the AKT pathway altered cohort, the benefit is still maintained here. That is PFS of 5.4 month versus 1.9 month, with a hazard ratio of 0.47 with significant p-value. If you see the intention to treat population, the PFS hazard ratio was 0.61, and here the hazard ratio is 0.47, which shows that the benefit is more pronounced in patient with AKT pathway altered cohort as compared to the intention to treat population. Next slide. Now coming to the another secondary endpoint, that is PFS by BICR. So here the outcomes are still same, but numerically the PFS is higher here. In ipada arm, that is 9.71 versus placebo 3.71 with a hazard ratio of 0.65. So why the numerically the PFS numbers are higher here is unknown, and it was not disclosed at the time of publication. So we don't know why in BICR assessment the benefit is same, but numerically the figures are both higher in the both the arms, with a almost similar hazard ratio of 0.65. Next slide. Now again the PFS by BICR in the AKT altered pathway. Here the figures are even higher, that is 12 month versus 3.6 month, with a hazard ratio similar of 0.50. So in BICR assessment, numerically the figures are higher in both the arms, but the benefit, if you compare, it is similar with the investigator assessment, that is hazard ratio of 0.50 and 0.65. Next slide. Now one more exploratory analysis, that is PFS by the ESR1 status. So it had almost 50% of the patient with ESR mutated cohort and the ESR wild type cohort. If you see the PFS analysis in both the cohort, the benefit was there with the addition of ipadasertib, but the benefit is more pronounced in ESR wild type cohort as compared to the mutant cohort, with a PFS of 5.5 month versus 2 month in the wild type, as compared to the 3.7 month versus 1.8 month in the mutant cohort. So that means benefit is there irrespective of the ESR mutation, but the benefit is more pronounced in the ESR wild type cohort. Next slide. Now secondary endpoint, that is OS. At the time of publication, only 50% maturity for the OS was achieved, and there was no OS benefit with the addition of ipadasertib, that is 23 month versus 24 month with a hazard ratio of 1.07. So there is no OS benefit at present, and I think we need to wait for the final OS data to conclude on the OS benefit or not. Next slide. Now in short, the adverse event, definitely the toxicity was more with the addition of ipadasertib to fulvestrant, with common side effect being the diarrhea, nausea, hyperglycemia and fatigue. But if you see, the green color is the grade 1 adverse event, blue is the grade 2, and yellow is the grade 3. So most of the adverse event were grade 1 and grade 2, and only grade 3 adverse event which was significantly increased with the hepatocytic was diarrhea, and that was only 16%. So that means this combination is fairly tolerable with slight increase in the grade 2 and grade 1 adverse event without such significant increase in the grade 3 adverse events. Next slide. Now, reason for discontinuation, most common cause for discontinuation was the progressive disease, that is 67% and 78%. But if you see the discontinuation because of adverse event was slightly higher, that is 6.5% with hepatocytic versus only 0.8% with placebo. So there was only slight increase in the discontinuation rate because of toxicity with the addition of hepatocytic. Next slide. Now coming to the conclusion. So this trial included patient with ER positive, HER2 negative MBC patient immediately post progression on first line treatment with CDK4/6 and AI with the real-time ctDNA genotyping. Targetable mutations are quite common after progression on CDK4/6 and AI, with the most common mutations being the ESR1 and AKT pathway. And this new combination of ipatasertib and fulvestrant is very tolerable, and it definitely improves the PFS both in intention to treat and AKT altered pathway code, which is statistically significant also and clinically meaningful. And that's why this offers a new potential treatment option for this group of patients immediately after progression on CDK4/6 and AI in the first line setting. Next slide. So that was my last slide. Thank you.
Thank you very much, sir, for such a comprehensive talk. So it's my pleasure to now invite Dr. Pinaki, sir. Sir, over to you.
Yeah, please share my slides. We're half an hour behind schedule, so I'll try to be as fast as possible.
Yeah, sure.
You can share.
Yes, sir, doing.
So unlike the previous slides, this is very simple to understand. So basically, it was exploratory analysis via biomarkers of the efficacy of trastuzumab deruxtecan versus physician's choice of chemotherapy in the HER2 low, ultra low hormone receptor positive metastatic breast cancer patient. This was primarily the Destiny Breast 6. So we are just looking at whether the presence of the biomarkers did affect the efficacy of trastuzumab deruxtecan versus chemotherapy. Next slide. So I will just discuss the key takeaways. Basically, in short, the long and short is that it did not impact. DDXT did have an efficacy benefit in all the subsets, whether it was mutations in the PIK3 AKT pathway, ESR1 or the BRCA1/2 mutation status, and this was consistent with that of the overall intention to treat population, and therefore we can use DDXT in all these subsets. Next. So we know that Destiny Breast 6, it was a randomized open label phase 3 study that basically showed a clinically meaningful PFS benefit with TDXT versus treatment physician's choice of chemotherapy for patients who had a hormone receptor positive, HER2 low or HER2 ultra low, who had progressed after one or more endocrine based therapies. These were patients who had not received chemotherapy previously, and they were not suitable for subsequent endocrine therapy as the next line of treatment. We know that now we have, as has been discussed, we have now multiple targetable biomarkers, that is PIK3 AKT pathway, ESR1 and BRCA1/2 mutations. And therefore, whether we can use TDXT in these drugs, in these pathways, and as well as get the benefit is what was the point of doing this exploratory analysis. Next. So this is the trial design. As previously discussed, these patients had hormone receptor positive metastatic breast cancer who had a HER2 low, that is, IHC 2 plus with a ISH negative, or IHC 1 plus, or a HER2 ultra low where you have IHC 0 with some membrane staining. They were chemotherapy naive in the metastatic setting. They had received prior lines of at least 2 or more lines of endocrine therapy plus minus targeted therapy, or they had received one previous line for MBC, but there was a progression within 6 months of the starting the first line CDK4/6 inhibitors, or within 24 months of starting the adjuvant endocrine therapy. These patients were randomized 1:1 to receive the TDXT versus physician's choice of chemotherapy, this being capecitabine, nab-paclitaxel, or paclitaxel. A lot of these patients had de novo metastatic breast cancer, almost 1/3. 67% patients had liver metastasis, visceral disease in 85% of patients, and around 1/3 of patients had primary endocrine resistance. So definitely this is a difficult to treat subgroup of patients. The primary endpoint here was the PFS, which was shown to be significant, 13.2 months versus 8.1 months in the overall population. Secondary endpoints were again the PFS by the blinded review. That was again significant, 13.2 versus 8.1. Also, we looked at the data, at the OS data, which is only 40% mature as of now. We also looked at the PFS2, safety, tolerability, and then this biomarker analysis as we are going to discuss today. Next. So how was it done? So basically blood samples were collected at baseline and then sequentially this was the Guardant Omni 500G liquid assay. The PIK3 AKT pathway, including the AKT1 PIK3C activating mutations of fetal loss of function, as well as the ESR1 and BRCA1-2 mutations were investigated. Both somatic and BRCA mutations were considered here. Out of the 625 patients, I think almost out of the total 886 patients, 625 patients they were able to evaluate. There were some patients who were not included, and there were some patients which, because of the low tumor burden, they were not considered significant to be included in this biomarker assay. Next. So if you look at the biomarker evaluable population, that is the PEP or the intention to treat population, you can see that the median PFS is almost similar. In fact, it is better in the biomarker evaluable proportion. It is 13.9 versus 8.2, whereas in the intention to treat population, it is 13.2 versus 8.1, both being statistically significant. Next. Again, if you look at the curves, now let us talk about the individual biomarkers. So if you have a PIK3 AKT pathway mutation status, you can see that whether the mutation is there or not, the curves do not change for the trastuzumab deruxtecan in the wild as well as the mutant population. In the mutant population, you can see that the median PFS is 13.2 versus 7.1 months, the hazard ratio being statistically significant 0.65. So definitely in this pathway, we can use this drug. So a lot of discussion we discussed now today about different types of PIK3 AKT inhibitors, but you can see that TDXT also works in this subset of patients. It is still effective despite this mutation. Next. Looking at the ESR1 mutation, yes, patients who had the ESR mutation, they did less better as compared to those who did not have it, but still the difference between the curves was maintained. The PFS in the patients who had an ESR mutation was 11.3 versus 7 months, which was again statistically significant. So yes, it does work in this subset as well. Next. Again, if you look at the BRCA1 mutation status from the baseline, these were less number of patients. You can see that TDXT somehow did very well, 21.4 months versus 5.6 months. The hazard ratio is, the PFS is only 0.1. But I think the number of patients were less in this subset, so it again difficult to understand. But yes, there is a potentially greater benefit with TDXT in this subgroup of patients. You must keep this in mind. Next. So if you look at the overall response rate, you can see that the curves of the overall curves of TDXT are superseding everything else, whether it be the PIK3, the BRCA, or the ESR mutation status. Definitely, we can get a higher overall response, and this is important in the metastatic population where you want good response in the patients who are symptomatic disease. Next. Again, when we look at the forest plot, we can clearly see that the hazard ratio is statistically significant, and this is for the subsequent progression-free survival. So even if you have used TDXT, for the subsequent PFS also, there is a benefit of using this for these biomarker subsets. Next. So the conclusion here was that irrespective of the type of biomarker that was involved, whether it be a PIK3, AKT, a ESR1, or a BRCA1-2, the median PFS was improved and it was statistically significant in all the three subsets. And this gives us inspiration to use these drugs, use TDXT as a drug in this if you have got a HER2 low or a HER2 ultra expression. Next. Next. So they just compared the baseline characteristics. To my mind, there was nothing very different in the baseline characteristics among the intention to treat population as well as in the patients who had received in the different biomarker analysis subsets. I think most of these patients were having the visceral metastasis, liver metastasis, and 1/3 of the patients had endocrine resistance. Most of these patients actually had secondary endocrine resistance rather than primary. Next. I think this most of these patients they have not received the biomarker directed therapy. So that is one caveat of this study, because what we are doing is we are using chemotherapy as the control arm, whereas normally, as we have discussed earlier, now we have got treatments that against the PIK3 mutations, ESR1 mutations, as well as for the BRCA alterations. So maybe a more practical approach would be to consider and compare TDXT versus the biomarker directed therapy rather than chemotherapy. That is, I think, the main drawback of this analysis. Next. Next. So the safety analysis, again, I think the grade 3-4 toxicities were less with were more with TDXT, but the number of discontinuations were lesser, and there were few deaths in the TDX3 arm. So again, we know that some of the patients might develop fatal pneumonitis or some other complications. So that is something always to be kept in mind. Though I agree that in a heavily pretreated endocrine refractory population, we don't have much options to use anything. So I think that concludes. This was, I think, the last slide. Thank you all for the patient. I think this is the concluding slide.
Thank you very much, sir, for the learning focused talk. So now I would like to invite Dr. Tejinder, sir. Sir, over to you.
Yeah, you will present from your side?
Yes, sir, will do.
So I think we are running short of time of almost half an hour. So
Yes, sir.
what I'm going to discuss is going to be looking at the role of ADC along with the PD-L1 inhibitor. So this study basically is known as ASCENT-04 Keynote D19 study, looking at combining the ADC plus Pembro versus chemo plus Pembro in patients who are advanced metastatic triple negative. So triple negative ADC plus immunotherapy. Next, so it's a phase 3 randomized study, ASCENT-4, and the main reason why this study was looking at, because they are looking at a better treatment option in a first line, especially patients who are PD-L1 and metastatic cases. And there was a small study previously which had shown that when you combine ADC with the Pembro, there was a meaningful improvement in PFS versus the chemo plus Pembro. So that's the reason why this results do come into a prominence, that why not it should become a first line standard of care. Next. So this is a similar one, why they had put the rationale, because we know now a bulk of the patient of triple negative are basically PD-L1, around 40%. And they had found that when you are giving, which is nothing but a SG, which is at only TROP2-1, and it has shown an overall survival benefit in multiple phase 3. Now it has got approval for a second line metastatic also, and pre-treated patient who HER2 and hormone positive and HER2 negative. So early studies have been very clear that these two drugs can be combined. And so that's the reason why phase 3 ASCENT-04 Keynote D19 study has come into place. Next. So bulk of the patients are PD-L1 positive. So this is a study design. They are looking at patients who are PD-L1 positive and CPS more than 10 and more than 6 months since the treatment in curative setting. So it's a first line basically. When we combine the SG with Pembro versus chemo versus Pembro, and they had the primary endpoint was a PFS, secondary was OS, and the overall response rate. Next. And they had stratified the patient on other factors. So this was a statistical analysis looking at what should be the enrollment. They had planned to take 440 patients. Next. Demographic baseline were quite well matched. You have patients who had recurrent within 6 to 12 months, more than 12 months. You can see around patients who had were recurrent more than 12 months were the majority, 50%. And de novo also was there. 35% getting a de novo was quite a big number. Next. So this is a PFS. I think important thing to here is to see the 6 months and 12 months PFS. The curve started quite early, 2 months onwards, they started separating. So your PFS rate is 6 months was better, 72 as compared to 63. 12 months, it was around 48 and 33. So the important thing to understand is that the curves, even at 12 months, were quite separated. And there was nearly 35% reduction in the risk of disease progression or death. Next. So there was a meaningful improvement in the PFS. This is an investigated assessment based on the PFS. There also you can see a difference. So consistent with whatever we got the report from the last slide. Next. So PFS improvement, and this is a subgroup analysis. Here, important thing for me to see is the curative treatment-free interval. You know, those patients who had recurrence nearly 6 months, and or those patients who had recurrence even after 12 months, both showed a good response. And a de novo patient also had a good response. So the PFS benefit was observed across all the subgroup when you're looking at this particular combination. So ADC plus PDL1. Next. So this is the overall analysis and you can see nearly 81% patient who received any subsequent treatment after discontinuation of chemo and pembro, they received ultimately the sacituzumab. So this is immature data, not mature data. However, there is a positive trend for improvement in the this particular combination. Next. And these are the tumor responses. I think we have now started, when we talk about looking at the role of PDL1, we look at whether the duration of response, what is there. And you can see clearly the median duration response you can see in a immuno plus ADC is 16.5 months as compared to chemo plus pembro. So there is a substantially longer duration of response and higher overall response rate, which were observed in the ADC combination. Next. And this is the safety summary. I think we do discuss whether this drug is particularly safe or not. In spite of longer duration of treatment with the ADC and immuno, the rates of grade 3 adverse event were similar for both the groups. So how many percent of the patients who had ultimately had to discontinue or dose reduction was around 30% patient had to reduce the dose. Next. These are the most common. I think we know that when we are giving adverse event, when we give ADCs, slightly more amount of neutropenia, fatigue, and nausea, and the adverse events were consistent with the known profile. Next. So this drug SG is coming up in a big way, but there were no new safety signals, and there was no increased rate of adverse event when you combine the ADC with the pembro. Next. So to conclude, this is the first study, keynote D919 and SN04, which looked into this particular combination, and it has shown a statistically significant and clinically meaningful improvement in the PFS, which is the primary endpoint, a median of 11.2 versus 7.8 months across all the subgroup. OS data is still immature, but early trend is showing improvement. And overall response rate, there was some patient who had a complete response also, and the durable response. So safety per se has not shown any new safety data and no addictive toxicity. So this drug basically this trial is very nice trial to really look into it, whether SG can be put up in a first line. And based on this trial, this can become a standard of care for the patient who are untreated, PDL1 positive, locally advanced, unresectable, or metastatic triple negative. Thank you.
Thank you, sir, for the insightful talk. So now I would like to invite. It's my pleasure to invite Dr. B.K. Smurthy ma'am. We only invite to join as a moderator for the critical review webinar on HER2 negative metastatic breast cancer. Your expert input would be greatly valued. Over to you. Hello.
Yeah. Can I share my slides or?
Ma'am, it is
Sharing it?
already shared.
Okay. Okay.
Yeah.
So, we've had very interesting abstracts, mainly related to hormone receptor positive, HER2 negative. And then finally, we had something on the HER2 low and the TNBC. So very, very interesting abstracts, and with a flurry of drugs, especially in the hormone receptor positive group. Now, coming to all these, I just invite my panelists. So we have Dr. Advait Gore. Is he there? Dr. Ravi Jaiswal, Dr. Samir Shirangwar. Are they all there?
Yes, madam.
Yes,
And
yes.
I came to know that Dr. Seker has left. Is that true, or is he there? Okay. So we proceed with our three panelists. Now, let me run through quickly because next slide. Next slide. I think so. We look at the unmet need in this population. Next slide. So we can just see that though it forms the largest group, almost 70%, if you look at the 5-year survival, it's much inferior to those who are HR negative, HER2 positive, or the HR positive, HER2 positive. So these group of patients have a inferior 5 years survival as compared to that. Next slide. And then if you see that, if you look at this population, the first line response is the most important, that is 24 to 28 months. And then you see it precipitately drop. So, you need to just improve on your first line and then also try to improve on subsequent lines. So let's come to the extracts and go to the next slide. So let us look at the key abstract. So the Serena 6 study, where we have this camizestrant with continuing with the CDK4/6 and also the AI with CDK4/6 and placebo for camizestrant. So this is mainly you're looking at monitoring the ESR1. Maybe it was done almost every 2 months. Of course, and then when they saw that the ESR1 was rising, then these patients were then randomized to this drug camizestrant versus no camizestrant with the routine endocrine therapy. So next slide. So let me ask first Dr. Advait Gore that are there any barriers to patient identification with the ESR1 testing?
So, madam, we've seen that ESR1 is generally a secondary event. This generally doesn't happen upfront. Patients whom will I test for ESR1 testing? So, someone who has undergone maybe 2 lines of therapy and still is progressing very aggressively, these are the patients that I would send for ESR1 testing. Other group of patients where I would do ESR1 testing is patients who relapse very soon after initial line of treatment, especially if they've received extended adjuvant hormone therapy with aromatase inhibitors. This is the third group of patients whom I would ask for an ESR1 whenever there is a metastatic disease. Now, currently, as we are doing biopsies for all patients when they progress, we do have a tissue with us to do the ESR1 testing on. So I don't see that tissue is a reason why that should be a barrier that we are not able to identify ESR1 for patients. And now the ctDNA is also available to get ESR1 testing on that. So if we look at de novo patients, only 4% incidence of ESR1 mutation has been reported from the Mona Lisa study. While as we look at the third line data, almost close to 40% patients have ESR1 mutation which has been detected.
Yeah, so that's the thing. And of course, because we are doing NGS, we can get the ESR1 mutation, but otherwise, digital, DDPCR is also another technique.
Yes.
But I
Yes.
checked with quite a few labs. So they do not have this in place as yet. So it would mean that it still have to go with the NGS. So now coming to Dr. Ravi Jaiswal, already, I think Dr. Advait Gore has already mentioned about proportion of patients who develop ESR1 on progression. So do you think that the regular ctDNA testing is a feasible strategy in Indian patients? And how comfortable are you with the results? And what are the challenges with ctDNA testing?
I think, ma'am, ctDNA is a fantastic tool, but the problem is with the mindset of physicians like me. For example, let's say a patient of EGFR lung progresses, and there we are very keen to look for T790M because we have a wonder drug there. Here, because we still don't have in our practice a wonder drug, which even if we find ESR1 mutation would increase the overall survival of the patient remarkable. We as physician itself are little hesitant to offer this test, and the mindset has to change. And coming back to your question, I think regularly doing ctDNA is a feasible strategy. Yes, we can do. I think the challenge, apart from the cost, I don't see any challenge. I think we can, for a patient who is affording, I think we can do this test, monitor it, and we can offer them the novel therapy.
Yeah, so that is important that till now we have only fulvestrant as one of the drugs. When patients progress on AI with the CDK4/6 inhibitor, and since we were actually going to the SERDs any which ways, we were not testing for it. But if we are having better drugs which are more specific, then and better than fulvestrant, we would definitely want to look at these mutations. So next slide.
Ma'am,
Madam, now even in adjuvant situation, we do have PADA1 data which looks at changing to fulvestrant if the ESR1 becomes positive.
Yeah, I know, but are you then using it as yet?
Not yet.
Not in the
Not yet,
guideline.
madam.
So,
Not yet in the guideline.
yeah, so
Yes.
even though we have very good data here coming about testing for either ESR1 and PIK3CA, the AKT pathway, we have been using it, but in the lines of therapy that you mentioned and not early on. I think if these data mature and they show the benefit, we would be then transitioning to early on testing for this. So you can see the primary, yeah. Anybody?
Ma'am, sorry, ma'am. Anderson here, ma'am. I presented this Serena 6 study. Ma'am, with regard to testing ESR1, I face the challenge because they almost screened 3,300 patients for the study, ma'am. Only they recruited 10% of population, 358. So almost we need to 10x time the patient should be screened for so that the patient should be eligible for the study. And also, even the patient were ESR1 positive, there is a significant dropout is there. Almost 500 patients out of 3,300 were ESR1 mutant positive, but only 350 patient has been selected for randomization into the study design. So there is a significant dropout even after those patients who are having ESR1 mutation positive is also there. So doing this test into a 10x time will be little difficult also. That is my opinion, ma'am.
Yes, I think that's an important point. And second thing is, the one point which has been brought up is you just have a positive and negative, but you don't have a VAF here. So that is another limitation of this. So can I ask you whether there was any value to that in this study? Dr. Anbarsan?
Ma'am, yes, ma'am. Yes, ma'am. Actually, they have certain values. One is if the mutation is detected at the first line of testing, in those patients, it is showing the possibility of better response, ma'am. But with respect to positive or negative, they are not. I don't see any comment to that, ma'am.
Yeah. So next slide. I think we'll have to move quickly. I don't have the control of my slides. So I think let's skip this because there weren't many safety signals over here. It was quite a well-tolerated drug. Next slide. Again, next slide, please. As a photopsia was one of the side effects, but that was not so significant. It was a small percentage who had that. So do you think that we can adapt this switch strategy in India at the moment? Let me, yeah.
I will take with a pinch of salt.
Mm.
Because here the majority of the patient who receive CDK4/6 inhibitor is palbociclib. Almost 76% of patients receive palbociclib as a backbone. Whereas in our real world practice, almost everyone has shifted toward ribociclib if the patient is affordable or abemaciclib. So palbociclib alone, that is again one of the drawback which we need to see. And second thing is, we all know that monitoring ctDNA, ESR1 mutation will always prognostic. It will determine the patient will have a bad prognosis. Whether it is a predictive or not, only when we have the overall survival data, we will come to know the real world picture. Again, there will be a question that the patient is also showing a PFS2 advantage. But the catch over here is patients as a second line chemotherapy received in the experimental arm is almost 40%, whereas in the control arm it is only 30%. Almost 10% difference is there. Probably that may also contributed to the better PFS2 advantage with respect to camizestrant. So we need to monitor this trial over a period of time. We need a longer follow-up data before changing it into the practice.
Yeah, so I mean, this is promising results, but we need a longer data, and you very nicely pointed out the limitations. So we should keep that in mind. So at the moment, we do not adapt this strategy, Swiss strategy in India. Next slide. So now coming to the next study where we have the inavolisib along with palbociclib and fulvestrant versus palbociclib and fulvestrant in the PIK3CA mutated population. An important study. Next slide, please. And of course, where the median PFS was concerned, it was a positive study, and you can see a vast difference, 17.2 versus 7.3. The improvement was maintained during the longer follow-up. Next slide. And overall survival improvement in by 7 months. But the pre-specified boundary for statistical significance was crossed. So I think this is the other important study. Next slide, please. So coming back to our panel, a patient with PIK3CA positive HER2 low at metastatic diagnosis. So how do we choose? Would you give the PIK3CA mutation these drugs first, or then treat with TDXT, or combine both, or something else? So can I come to now Samir, Dr. Samir Shirangwar? Is he there?
Yes, ma'am.
Yeah.
So ma'am, that's a tricky question. So we don't have any head-to-head comparison between the both the options which you are mentioning. But I think I would always go for target therapy, which is for when there is a specific mutation is present. So if the PIK3CA mutation is present, I would go for inavolisib, fulvestrant, and CDK4/6 combination, and keep the TDXD reserve for the next line. But I think both the options are valid. We can use both the options. Sequencing, definitely we need more data, both for both the strategies and OS data also. Unless and until we get head-to-head comparison, I think single best answer we cannot give. It will be always a personalized decision. But I think when there is a target, I would always go for the target therapy, targeting the specific mutation.
Okay, so basically, as I said, I know this is a tricky situation with the PIK3CA positive and HER2 low. Now, let me ask the other panelists just quick selection, whether Dr. Advait Gore, what would you select?
So, madam, I would go ahead with targeting the PIK3CA because this is a truncal or a clonal mutation, which is always will remain. I think that's the pathway which needs to be targeted first. But in a de novo metastatic setting, we currently do not have data even for targeting the PIK3 kinase. This subgroup of patients who were included in the trial were the ones who were thought to have a very high risk group, those who have progressed following completion of endocrine therapy within 1 year of end of treatment or on while they were on adjuvant endocrine therapy. So when a de novo metastatic patient is coming in who's coming with PIK3 kinase positive and HER2 low, I probably will still not target the PIK3 kinase if the patient is having a long disease-free interval from completion of adjuvant, or if it's a de novo, I would still go with the CDK4/6 inhibitor and keep the PIK3 kinase as a second line. To answer that question, whether IO 121 has been currently looking at that answer, whether alpelisib or inavolisib has been a proper combination with fulvestrant. So this study actually looked at patients who were progressing very early in a very high risk group of patients.
Yeah, but here we are asking you whether you would prefer TDXT or a PIK3 inhibitor. So you feel that
Neither, something else. That is what my answer would be.
Okay. So Dr. Jaiswal and then Dr. Samir quickly.
I think, ma'am,
Quick answer.
for this
Which one?
for this question, I would target the PIK3 mutation first, and then TDXD would be after that.
And what about Dr. Samir?
He already answered.
Acha,
He-
Yes, ma'am.
Dr.
Already
Sekar?
answered.
Sekar? Dr. Sekar is there?
Anbarsan.
Ambarsan?
Ma'am, I also go with the panel, ma'am. Maybe I will prefer. I don't prefer P3 inhibitor in the first line, ma'am.
Yeah, so I think, see, TDXT is beneficial irrespective of so many things. So that was one of the last but one presentations. And the PIK3CA mutation doesn't alter the benefit of TDXT. So I think in this, I would go for TDXT and then follow it up. But of course, one would again look at the PIK3CA mutation whenever they progress. So that is the argument for TDXT first. And then if you say that will you lose the PIK3CA mutation if you took TDXT first, we don't have the data. So I think it's still we are all this way or that way. But I think if it's an aggressive disease and with a crisis, we would go for TDXT. Next slide.
Also, ma'am, the PFS, I
Ma'am,
think with Inavo was around 17 months. And with TDXD, I think I remember it is around 12, 13 months. So the numerically, even though it is indirect, the PFS data looks better for Inavolisib.
Okay, so
Ma'am,
yeah.
what we've seen from our real world experience, we have given close to 50 patients with TDXD, especially with low HER2 and including HER2 positive setting. What I have found out was it's better to start TDXD little earlier. If you wait till the end of progression, the response rate is not that great we expect. That is also there. We need to have a calculated discussion. And
Yeah.
recently, one patient I have started with alpelisib. She's 70 years old, extremely frail. She's failed to all lines of therapy. We have not tried for antibody drug conjugate. And then I started with alpelisib at a very low dose, but she responded beautifully well. I don't know, maybe targeted therapy may have such innate nature. Even at late stage, also, if the patient is positive, then we should consider even at late stages also.
Yeah.
That's my opinion.
And we don't have a data on which sequence is better. But I think there are some trials in progress looking at which sequence is better. So next slide, please. Next slide. I think we will have to move fast. I don't have the control of my slide. So if you could just. So is triple therapy upfront the way forward or the sequential? I think we don't have the data for this. Anyone wants to comment on that? Anybody?
Triple therapy is for this select subgroup of patients, madam. I don't think it is for everyone. For all other patients who don't fit this criteria, we would still go with the sequential therapy.
Yeah. So next slide. So we come to this group of patients that is, very difficult. I just say VD, WebD, it's a tongue twister. So one SERD versus the other. And that you're looking at the PFS by ESR1 and then all patients. So next slide. Since the presentation was already made, we'll move on quickly to the next slide. Yeah, so you can see that the new SERD definitely is better in terms of 7.4 versus 6 months. It was still significant. When you look at the PFS by BICR with ESR1 mutation, so you see that 0.57 and it was significant. Next slide. Next slide. And all patients, of course, the hazard ratio was a little worse and the p-value was not significant. Next slide. And let's skip this safety and tolerability because we are running short of time. Let's come to the question. Next slide. So Now, this is would you incorporate a PROTAC in your current treatments strategy? So what do you have to say on that? Because this is a PROTAC inhibitor. I mean, PROTAC, it degrades the ER. So what do you have to say for that? Can I ask Dr. Gore?
Madam, I think Protax currently we would use only as single agent. Ideally, I would love to see a trial combining this with a PIK3 kinase or a CDK4/6 inhibitor. However, we'll have to wait for those results. We already have data for Elicastant and Capivastrant along with CDK4/6 coming in, along with PIK3 kinase coming in. So there is lot of renewed discussions about these estrogen degraders coming in now.
Okay.
But currently, I would use it as monotherapy.
Yeah. So,
Ma'am, we are part of this Veritex study. In a team under Sudeep sir, we have run this Veritex study. One interesting thing to note down with the newer molecules like SERD, Protac, or Serca, what is the thing is they are having least side effects compared to the routine endocrine therapy which we are using. We know the complaints will be very poor. For the safety purpose, these drugs are pushing up from metastatic to adjuvant setting also. There are so many trials running currently with the third and newer circle, specifically for the benefit of safety profile. Safety profile is much good. Probably this might be upcoming in the future. Probably we see the replacement for endocrine therapy or in addition to endocrine therapy in both in the metastatic setting as well as in adjuvant setting if the results are good. But currently not there.
yeah, thank you. That was an important input from your side. And I think, I'll skip this thing on serans because we have not included that in our, and it's more of investigational. What you have already answered is on the SERDs and the PROTACs. Dr. Ravi Jaiswal, you want to add anything before we move on?
No, ma'am. I think for this selected group of patients who have progressed and who have this mutation, I think the PFS is significantly better, and we can you incorporate this in our practice. But yes, overall survival is awaited.
Yeah. So can you move on to the next slide, please? So now we have the EMBER-3. So now you have the imlunestrant alone or with abemaciclib and in the standard of care. So next slide, please. There was a detailed presentation, so let's skip this. So it was mainly beneficial in the ESR1 as well as the all patients. So let's go to the next slide. So assuming that the availability of multiple SERDs, do you have any preference in your first line? So can I ask Dr. I think Dr. Samir has left. So can I ask Dr. Sekar? Are you there? Anbarasan? Are you there, doctor? Okay, then we move on to Dr. Gore. Would you answer this?
Yeah, so I think, madam, we are still looking at how all of these SERDs are going to be used in practice. Irrespective of ESR mutation, currently the data is still evolving as to which one is better because there is no head-to-head comparison. I think I would go with the side effect profile. And in terms of side effect profile, also, these are such drugs which have very few side effects. So early availability, more compliance would be with an oral formulation as compared to fulvestrant as what we are using. So currently, what is available, even as a name patient basis, is Elicastant, and that is what I'm using for patients when ESR1 mutation is there and patients have failed fulvestrant.
Yeah. So of course we have a paucity of these drugs and their availability. So we are restricted by that. But it was just that if the multiple SERDs were available, what would you select? And definitely not only the route of administration, but even the efficacy wise, the newer SERDs are better than fulvestrant. That's quite obvious from all these. Dr. Jaiswal, you want to add anything?
No, ma'am. I think I
Yeah. So
agree
can
with
we,
nothing else to add.
can we move on quickly to the next? Are we running short of time? Please let me know. Otherwise, let's move on, please. Go ahead. So we know about the safety profile. Can you move ahead to the next slide? Yeah, I think this was mentioned in detail. So there was some quality of life issues because of the diarrhea and all. But I think let's move on. Move on to the next slide, please. So of course, this is a question which is how does the patient look at it and how would you look at it? But I think we move on to some more important questions. So can we move on to the next slide? So do quality life of parameters impact clinical practice? So I think I don't know whether Dr. Samir, I think, has left, but Dr. Sekar, are you there? Otherwise, then I'll ask Dr. Ravi Jaiswal.
Yes, ma'am. Ma'am, what is the question? Sorry, ma'am, I didn't.
No, do quality of life parameters impact clinical your practice?
Yes, ma'am. It is definitely important because nowadays the treatment practice has changed from stopping the therapy, definite therapy, to an infinite therapy. With the newer therapeutic molecules coming into the picture, pertuzumab, TDXD, it is a continuous therapy. So quality of life is definitely important in the current scenario, ma'am.
Yeah, and the longer you can, actually delay the chemotherapy, I think the quality of life with all these other molecules that we have discussed is definitely better. So next slide. So now coming to
Ma'am, sorry to interrupt, but we are running short of
yeah, so
time.
can
So
we
could you
stop here because I think even the presenters had had good discussions. So
Yes,
we
ma'am.
can move on to the next part of the program. So I'd like to thank all the
Thank you.
panelists for
Thank you,
giving their
madam.
views. Yeah.
Yeah.
Thank you, ma'am.
Thank you, ma'am, for sharing the sessions so gracefully. So now I would like to invite, it's indeed a great honor for me. So now hand over the session to one of the most respected and admired pioneers in the oncology, Dr. S. Shadwani, sir, a Padma Bhushan awardee and a guiding force for countless oncologists across the country. His presence with us today is truly invaluable. Sir, with utmost respect and gratitude,
Yeah,
I now invite you to take over the sessions. The platform is all yours. Thank you.
yeah. Dear friends, first of all, I would like to thank the organizers, AstraZeneca, for giving us this opportunity to really get together and discuss both HER2 negative and HER2 positive conditions. And in both the areas, the lot of developments have occurred. And we just heard for about an hour or so that how much progress has been made in the HER2 negative, HR positive breast cancer. Similarly, in the HER2 positive metastatic breast cancer, also the tremendous progress has been made. And this has been made because of the rapid development in the first, the Herceptin, which came up, then came the pertuzumab, and then, of course, we had the ABC drug like Katsela, and also similarly now the NR2. And I think in all these conditions, the newer and newer drugs are playing a major role. Particularly, I must emphasize again that NR2 has really done remarkable changes in our outlook towards the resistant HER2 positive breast cancer. To discuss all these things, we have along with us Dr. Prabhat Bhargava. He is a medical oncologist from Tata Memorial Hospital, and he will share with us the Destiny Breast 09 trials. Dr. Prabhat Bhargava.
Thank you, sir. Thank you for the kind introduction and words about breast cancer also. And so my topic today is the changing paradigm due to the Destiny 09 trial. Next slide, please. Yeah. So as ASCO has mandated, this is the best thing that you read the conclusion first. So conclusion is that PDXD with pertuzumab meaningfully improved PFS compared to the standard of care that we are still using, 30 HP. in for the patients with metastatic HER2 breast cancer in first line, and this may become further standard of care in future. Next slide. So we know from over a period of time, it was initially that trastuzumab was discovered, and it has shown in a randomized fashion that if you add trastuzumab to chemotherapy, you increase PFS by roughly 2-3 months, from 4.6 months in metastatic patients who have been treated with previous line to 7.4 months by adding trastuzumab. Next slide. Then came the one slide before. Then came Cleopatra trial. This is the standard of care at present, where that it showed that adding pertuzumab to the combination of chemotherapy and trastuzumab increases PFS from roughly 12 months to 18.7 months. And at 8 months, 8 years, 16% of your patients wouldn't have progressed. And in terms of overall survival, it showed roughly 16 months overall survival. But 8 years, one-third of your progress, one-third of your patient would still survive, is really remarkable. Based on this, the next trial was planned where ADC was compared to the existing standard of THP based on Cleopatra study. Next slide. But in the meantime, this new study also has come into picture. While Destiny 09 was ongoing, the Patina trial has also something enlightened us that patients who are ER positive, they need to be given anti-ER therapy, obviously with anti-HER2 therapy, and even CDK4/6 inhibitors. If you add CDK4/6 inhibitors as a maintenance therapy to initial anti-ER and anti-HER2 therapy, it leads to median PFS reaching to 44 months, which we saw was only 18 months when you did not give anti-ER therapy and CDK4/6 inhibitor. When you give only no CDK4/6 inhibitor, it was 29 months in this trial. Next slide. And we know from previous Destiny trials that TDXD is a very useful drug. It increases PFS compared to whatever standard of care you want to give. Instead of this if you give TDXD, the PFS is drastically better. As in Destiny 03, it was compared to TDM1. And compared to TDM1, there was 22 months of more PFS compared to what TDM1 would give. And that led to significant OS benefit also. Next slide. Then comes our trial of interest today, that is Destiny Breast 09, which is in first-line HER2-positive metastatic breast cancer patients who have not received any therapy for metastatic disease. And for if curative therapy was given, it was to be given more than 6 months back and not within 6 months. Such 380 patients were randomized to each arm of a TDXD plus placebo or TDXD plus pertuzumab or a standard of care THP followed by HP maintenance. For a primary endpoint of PFS, this readout was for 2 arms, TDXD plus pertuzumab versus standard of care THP. Next slide. So, next slide. Yeah, and the outcome is that PFS have significantly improved. The p-value of 0.0001 and hazard ratio of 0.56. From THP arm, it is 26.9 months versus the experimental arm of TDXD, that is trastuzumab deruxtecan plus pertuzumab, it is 40.7 months. So there is statistically increase in PFS, which is clinically meaningful. Also, we have to wait for whether it can lead to OS benefit. This is the interim analysis where only maturity for OS is only 16%. Next slide. So median PFS may improve further as current follow-up is short and 40% of patients are still on TDXD. And there was low use of neoadjuvant HER2-directed therapy. One should keep that in mind. Next slide. Toxicity-wise, the combination led to 12.1% having ILD and only 2 patients died because of grade 5 ILD. Otherwise, there were no grade 3 or grade 4 toxicity or ILD also. So if carefully given, there are no grade 3, grade 4 toxicities of ILD. And grade 5, I think, would have been missed by investigator early. So we have to keep in mind and keep on monitoring for ILD. LV dysfunction was 11% compared to 7.1% in THP, so slight increase in LV dysfunction is also there. But treatment-related adverse event possibly associated with death was only there in 5 patients. So overall, similar incidence of treatment-related adverse event, in fact, less numerically compared to what THP would have given, and more number of patients interrupted paclitaxel compared to those who could interrupt TDXT, could not achieve 6 cycles of paclitaxel also, or Texans also. And further data are awaited regarding quality of life. Next slide. So how do we integrate this data into our treatment algorithm? Next slide. Sequencing, could this be based on tumor sensitivity to tumor, or could there be induction and maintenance phases? This needs to be seen, whether we can give just TDXD initially and then give a TDXD plus pertuzumab initially and then trastuzumab pertuzumab. Next slide. The further data of DB09 says that PFS2 in THP arm it has been achieved. Total PFS2 is 36.5 months versus those who are still on TDXD plus pertuzumab, they have not reached the PFS2, but hazard ratio is 0.6 and p-value is again significant. So yes, we should start, if possible, patients into first line TDXD plus pertuzumab based on the PFS benefit that it gives in first line and second line. Next slide. How do we sequence HER2-directed therapy? So in Cleopatra and initially, you see that 25% of in THP have progressive disease at very early. So hyperprogression was there, which is less in DB0 if you give TDXD. Next slide. Next. And 16% of THP are 16% of THP as we saw initially in Cleopatra are say progression free at 8 years. So we still don't know who are these patients who have prolonged benefit from THP. Next slide. In PIK3CA, they had stratified based on the PIK3CA, and in PIK3CA mutated patients, the outcome was definitely better if TDXD plus pertuzumab compared to the standard of care. OS benefit in PIK3CA wild type is 73 with THP, but in mutated patient it is only 49.3 month with the standard of care. And PFS wise also, it seems that in wild type, the combination of TDXD plus pertuzumab definitely works better. And we know that from our previous moderation also that these are PIK3CA mutated patients in ER positive are worse cohort, and we need to act early for them. And same is true when they are even in HER2 positive patients. Next slide. How do we best sequence HER2 directed therapy is still a question. Long term, more common is if patients are de novo metastatic, longer DFI to initial treatment, they don't have any visceral disease. Roughly 26% had no visceral disease in this trial also in either arm. And those who are strong HER2 positive or they are PIK3CA wild. Next line. HER2-DX assay is an upcoming thing and can definitely point out and will be used in our day-to-day practice to see who are more HER2-driven tumors and may guide our therapy in future. Next slide. So those who have a favorable profile, they continue on treatment for a prolonged period of time. We know this with ctDNA, and those who have unfavorable, they relapse a bit early. Next slide. Now, this is a point of interest that what would be the duration of therapy with TDXD? Next slide. What about TDXD plus pertuzumab induction followed by HP? So here, percentage change in target lesion seen from baseline, you see that majority of patients could achieve a response at 12 months. But yes, there are patients who continue to respond at later, at 12 weeks, sorry, and later also. But yes, induction followed by maintenance can be an option even for TDXD plus pertuzumab. Next slide.
So, sir, sorry to interrupt, but we are running short of time. If you can conclude.
Okay. Yeah. So this is the summary slide that the combination is highly effective regimen in first line, but whether to give it continuously for till progressive disease or we can do some modification, initial induction followed by de-escalation needs to be seen further, and whether it leads to OS benefit needs to be seen further. Yeah. Thank you.
Thank you very much, sir, for the insightful talk. So for now, I would like to invite Dr. Mehboob Basade, sir, for moderation, and the topic is case-based panel discussion on HER2 positive MBC. Sir, over to you.
Good evening. Thank you for inviting me over here. I don't know, can you see the slides?
Yes, sir.
Okay. So thank you, AstraZeneca, and thank you, sir, for giving us the opportunity. And we will go ahead with the panel-based discussion. Let me invite my panelist, Dr. Pinaki Mahato. Are you there, Pinaki?
Yes.
Okay. Tejinder and Prabhat. Prabhat is obviously there. Tejinder?
So before you start, just one request from our side. Actually, we are running short of time, so if you can conclude early.
Yeah. I mean, I know. I mean, we are actually 8:15, 8:25. You are supposed to finish. We are starting at 8:25. So we will just see the gist and practical questions we can discuss out about what should be the sequence, what should be the treatment of choice for the patients with the brain mets and all those things. So I will just start with the one small case. Here is the 71-year-old female with the left breast cancer. She received 4-AC, 4-weekly paclitaxel that time, and also received the letrozole. And later on, when she recurred, that time she had in the lung disease, and that was, although it is ERPR positive and HER2 3+. So let me start with the Pinaki with you. Okay, so this patient received the trastuzumab at fulvestrant at that. In the current era, what will you start this patient on? So it is a metastatic disease, long interval, and has not received any anti-HER2 therapy in previous lines.
So I think it's very clear that we use a dual HER2 blockade, and now Patina has also showed that we can go with the CDK4 plus endocrine therapy. We can add in a CDK4/6 inhibitor in the maintenance. So using a Cleopatra protocol, I think, is the most logical way. We would not use this only trastuzumab in the metastatic breast cancer, especially when you've got a long phase.
So you will go with the Patina trial?
Yes, sir.
Okay, but Patina trial, remember that it has got the patient have already received the THP for 6 cycles, and those patients who have CR, PR, or stable disease, then they moved because they have already excluded out the bad prognostic patients. So those patients who have progressed, they have removed them from there.
So
these are
what I mean to say is,
from there they're going
for a what I mean, sir, is going for a Cleopatra-like regime, and then probably in the maintenance, then we are giving a dual HER2 blockade as a maintenance, add a hormone and a CDK4/6.
If the patient achieves some CR, PR, or stable disease.
Yes,
right?
Yes, sir.
Prabhat?
Yes, sir.
Your idea?
Yes, sir. But considering 71 years old, maybe no chemotherapy is also okay. I know there is no data to back, but age, anybody would be afraid. Considering I know TDXD can be given, but if patient defaults, nothing can be given.
But there is a pertinent data. Pertinent trial is without chemotherapy. So they have used fulvestrant along with the HP. So that has also achieved a good. Those patients who didn't achieve response, then they escalated with the addition of the docetaxel in the pertinent trial.
The pertinent trial, people who received hormone actually did better.
That was for neoadjuvant.
No. Pertinent is better.
That was in neoadjuvant setting. Okay.
No.
I will show you.
But actually, the patients who received hormone actually did better, sir, in that trial. Patients who received only hormone, they did better.
So the current NCCN guidelines suggest that in the first line you use like Cleopatra, TCHP, with the docetaxel or paclitaxel. Paclitaxel is preferred by some. You also have the data of Helen trial showing you can use nab-paclitaxel. Okay. Second line is the TDXD, and third line is the tucatinib or TDM1. Okay, so this is what the ISMO says, that if the patient is the HER2 positive MBC first line, give the taxane Cleopatra regimen, and then if they have a stable disease or obtain an objective response, then add palbociclib. That's what it is there. Anybody will use different regimen other than this? No.
No, sir.
Okay, so we know that Cleopatra has definitely shown, the first trial shown that the HER2 positive patients can live long, right? So how can make our other patients also live long? Because this Cleopatra was almost in 2012 and we are in 2025. So in last 13 years, obviously there have been changes which have happened. So to discuss that also, we will go that. We know that addition of pertuzumab to TDM1 didn't help. So Marin is a non-inferior, or we don't use that. This is the patina, what you have been saying, that 4 to 6 cycles of chemotherapy. Those patients who had CR, PR, or stable disease, then they move to the addition of endocrine therapy and palbociclib, not upfront. It is already those patients who are good patients, and there you achieved a median PFS of almost 44 months. That's what the patina trial is there. And we all know that. Pertinent trial is here. Where is Prabhat? It's here. So you can see Pertin was subsequently carried out after Cleopatra, although they didn't permit the endocrine therapy, and it showed that chemotherapy regimen free can also be given for the patients without an induction chemotherapy for that. Okay. So you have multiple options. If you look at the patient first. So I always say that what we are looking at is we are doing is a tumorized therapy. Looking at the tumor, we have to look at the person. So personalized therapy is more important. Look at the patient's criteria. Patient is fit for chemotherapy. Patient is not fit, hormone therapy and other thing, and then you can choose the treatment and go ahead. You have multiple options. If suppose this patient has an HER2 negative, then ERPR positive, you would have gone straight away with the endocrine therapy and CDK4/6. So here, in being HER2 positive, you can add anti-HER2 therapy also. So you can give the chemotherapy-free regimen in HER2 positive patients, right? Do you agree that? Do you practice?
Yes, sir.
So I have patients where a patient has brain met, received the radiation, skeletal mets, multiple fungating breast mass, extensive disease, elderly like 70, 71, and strong ERPR positive. I started initially with only because they were not fit for chemotherapy. So endocrine therapy dual blockade, and response is really dramatic and excellent. So there are certain unmet needs for the Smriti, as just discussed about DP3. We also have to know about the patient has visceral or bone mets, and how the oral general condition of the patient from the. So in short, based on, we know that the Cleopatra trial and Destiny trial, Prabhat, let me ask you, because you couldn't complete that slide, that what is in your mind? How do you think that you will sequence now the patient of HER2 positive MBC comes to you?
So in my mind, if patient is not in vessel crisis, then I will continue THP presently. And then presently, so I am not switching on to TDXD plus pertuzumab for any of the patient, because the OS benefit is not yet documented. And giving for 44 months for any patient would be difficult. With combination of TDXD and pertuzumab, TDXD alone would be difficult. So I will wait for OS benefit to come to change my practice. THPC will still remain as my standard of care, and especially in light of patina for hormone positive, so all the more reason patina will stay as standard of care.
I have a patient who is now almost 81. She's receiving this she received THP initially and now only Fesgo for 8 years. Now she said, I don't want to come. And she is in CR by the PET scan. So do you advise that we should give the treatment-free interval for the patient?
So there are phase 2 trials which are looking at this. If you have a response after 3 years, you can stop it. And I think they are looking at it. But obviously, a patient who stops treatment has to be monitored very intensively to see whether they get a recurrence.
So same thing is also coming in the Destiny also, because people are also looking, because you can't go on giving the TDXD for, like he said, that 14 months is the median PFS. Obviously, there are patients who are going to go beyond that. So we have to decide when to stop if the patient is in CR, both ways. So we have now THP regimen, which is established. And if there is a progression, you go with the TDXD or TDM1.
The TDXD.
TDXD will be preferred, especially for the brain mets, right?
Yes, sir. Yes, sir.
Pinaki?
Yeah, I agree. I think the Destiny Breast 3 pretty much showed us that that is the way to go. That is the only way to go.
And do you think where will be the role for the TDM1 now?
It is difficult. After TDXT, whether TDM1 is going to work in the first place, it is difficult. But they have put it in the algorithm down the line if you use TDXT proximally. But then I'm not really sure how much would be the response to TDM1 once you have exposed them to TDXT.
Okay, because the tucatinib and with chemotherapy and trastuzumab, that's the third line approval right now, especially with the brain mets. And we know that by the time they reach to third line, they will have the CNS mets.
As far as I remember, after ADC, TDM1 will have PFS of roughly 2.5 months. So
Yeah.
we will either have to add tucatinib or to check whether they are really left HER2 positive still, or they have become negative.
So even
use TDM1.
There is a real world Italian trial showing that if the patient receives the pertuzumab and HP combination, the even TDM1 is also not showing a good response.
Yes, sir.
So even the second line probably will be the TDXD, or with Destiny 09, it will come upfront. So message is clear that THP will be the first line, TDXD will be the second line, or whenever the OS benefit is seen, the sequence will change. The TDXD with pertuzumab will come as a first line and will move other things to other line. I think that will be the short discussion from our side, because organizers have already told us that we have to finish faster. So that's from me. And if you want to have any other discussion point, you can put it, and then we'll hand over to the organizers.
Thank you, sir.
No, sir, you have covered everything. Thank you.
Thank you very much, sir, for the perfect panel discussion. So now I would like to invite Dr. S. Shadwani, sir, for the closing remarks. Sir, over to you.
I think the whole sessions, both HER2 negative, HER2 positive, and hormone receptor positive, the discussion has been really in depth. And I think in 2 hours or so, all of us have really enriched our knowledge and information to the perfect online. And I think this is really going to help us to practice in a way that we have learned today. So Dr. Basade, Dr. Smati, they have really done a wonderful panel discussion so that all the questions came up with a particular answers. And I think all other speakers also have played a really major role. And I would like to thank each one of them for giving us this opportunity to listen to the in-depth information on the subject. And I'm also thankful to the AstraZeneca for organizing this online meeting. And I'm sure with this, we will again thanking them so that we can again meet sometime whenever the new development occurs. With this, I would again say thank you very much and bye-bye.
Thank you. Thank you.
Thank you.
Thank you very much, sir. Thank you, everyone. Bye. Good night.